Lecture series Uveitis part 7, and in this part we are going to discuss about Vogt-Koyanagi-Harada syndrome. Introduction. VKH is an idiopathic multisystem autoimmune disease featuring inflammation of the melanocyte containing tissues such as uvea, ear, and meninges. So basically it is an autoimmune disorders, and it basically involves the inflammation of those tissues which have melanocytes in them, like a uveal tissue, ear, and meninges. VKH predominantly affects Hispanic, Japanese, and heavily pigmented individuals, usually in the second and fifth decade of life. It is associated with HLA-DR1 and HLA-DR4 across different racial groups. So these genes are associated with them. VKH is sometimes subdivided into Vogt-Koyanagi disease, characterized mainly by the skin changes and anterior uveitis, and Harada disease, in which the neurological features and exudative retinal detachment predominates. So basically, Vogt further is divided into Vogt-Koyanagi disease and Harada disease. Basically, Vogt-Koyanagi has anterior uveitis plus skin changes, whereas Harada disease have neurological changes plus exudative retinal detachment (ERD) in the eye. So, what are the clinical features? They are going to be the prodromal phase lasting a few days, neurological meningitis and rarely encephalopathy with cranial nerve paresis and other focal lesions, and auditory manifestations, tinnitus, vertigo, and deafness. Cranial nerve palsies and optic neuritis may occur. So, basically, VKH have three phases. First, what will affect is the meninges or ear plus ears, then they're going to be the ocular involvement, and then they're going to be the skin changes. So this is how it is basically that. So in the case of the neurological lesions, there can be meningitis and some cranial nerve palsies, and in the ear manifestations there can be vertigo, tinnitus, and deafness. Cranial nerve palsies and optic neuritis may occur. Then there is a acute uveitic phase. Bilateral granulomatous interior and multifocal posterior uveitis with diffuse choroidal infiltration. Dallin-Fuchs nodule. Dallin-Fuchs nodule, see also sympathetic ophthalmitis below, vitritis, papillitis, and exudative retinal detachment. Ciliary effusion and iris lens diaphragm rotation can occur. So basically, in a case of uveitic phase, in the interior uveitis, they are going to be the bilateral granulomatous uveitis. So basically, VKH is always almost bilateral. So they're going to be the bilateral anterior granulomatous interior uveitis. In the posterior uveitis, there can be the multifocal posterior uveitis, and they're going to be the diffuse choroidal infiltrations. There can be the Dallin-Fuchs nodules. They're going to be the cells in the vitreous. They're going to be the inflammation of the optic nerve head. There can be the retinal detachment, which is going to be the exudative retinal detachment. Ciliary effusion and iris lens diaphragm rotation can occur. Then there is a convalescent phase, follows several weeks later. There is going to be the localized alopecia, poliosis, vitiligo, depigmented fundus appearance, sunset glow fundus, and depigmented limbal lesions. Sogiura sign in pigmented, especially Japanese patient. So basically, in a cases, you know that first there is a prodromal phase, then there is a uveitic phase, and then there is a convalescent phase, which basically include the skin changes. And in skin changes, they go with the skin changes in alopecia. They're going to be vitiligo. They're going to be the whitening of the lashes as well, and in ocular, they are going to be the depigmented fundus, which is giving the sunset glow fundus, and they're going to be the limbal lesions, which are going to be pigmented, which is the Sogiura sign. So let's see figure 12.19. It is showing the multifocal exudative retinal detachment in acute uveitic phase of the Vogt-Koyanagi-Harada syndrome, and it is showing 12.21 is showing sunset glow fundus. 12.20 is showing vitiligo and poliosis in Vogt-Koyanagi-Harada syndrome. So you can see the whitening of the lashes and the whitening of the skin as well. Then there is a chronic recurrent phase is characterized by smoldering interior uveitis with exacerbation. Recurrent posterior uveitis is much less common. Diagnostic criteria for VKH are set out in the table 12.8. So first, let's study about this. So there are 5 diagnostic criteria for the Vogt Koyanagi-Harada syndrome. First of all, there is absence of any history of penetrating ocular trauma, because if there is an ocular trauma, this is most likely to be the sympathetic ophthalmitis. We will discuss in the next topic. Absence of other ocular disease and bilateral uveitis. So these are first 3 features. Then they're going to be the neurological and auditory manifestations. Then fifth is the integral history, finding skin changes, finding not preceding onset of central nervous system ocular disease such as alopecia, poliosis, and vitiligo. So if there are incomplete VKH, criteria 1 to 5 must be present. In incomplete VKH, criteria 1 to 3 and either 4 or 5 must be present. And in probable VKH, isolated ocular disease, criteria 1 to 3 is present. So basically, if all these are present, this is called complete. If these 3 are present with either this or this, it is called as incomplete VKH. And if there is only first to 3 signs are present, then it is called probable VKH. Then there is an ocular complications include the choroidal neovascularization, subretinal fibrosis, pre-retinal and disc neovasal vitreous hemorrhage, affecting glaucoma. So these are all the complications that can occur with the VKH. Prognosis is variable and is partly dependent on achieving control in early stages. Neurological and auditory manifestations tend to resolve, but skin, lashes, and hair changes usually persist. So what are the investigations that you can perform? Systemic manifestations should be investigated and managed by an appropriate specialist. Lumbar puncture if diagnosis uncertain. CSF show a transient lymphocytic pleocytosis and melanin containing macrophages. So if we do LP, then there is going to be the melanocyte containing macrophages in the CSF and lymphocytic pleocytosis. FAF demonstrate areas of serous detachment. Ultrasonography shows the diffuse choroidal thickening and exclude posterior scleritis. Ultrasound microscopy can be used to demonstrate a ciliary effusion. FA of the acute phase show multifocal hyperfluorescent dot at the level of the retinal pigment epithelium, followed by the subretinal pooling. The chronic phase show RPE window defect. So in a case of a fundus angiography, they are going to be the acute phase and in a chronic phase. So in a acute phase, they are going to be the multifocal hyperfluorescent spots. Basically, it is the pooling that will occur. In a chronic phase, they are going to be the window defect. OCT allow quantification of the subretinal fluid. The subretinal septae are typical. So let's see figure. So this is an imaging of the ocular Vogt Koyanagi-Harada syndrome. A is showing the multifocal exudative retinal detachment in the acute uveitic phase. B is showing FAF of the eye demonstrating multiple exudative detachment. FA multiple hyperfluorescent leaking spots in the venous phase. D is showing the pooling of dye within detached area in the late FA image. E is showing OCT of a different patient on presentation showing subretinal septase. So this is a subretinal septase. The site of the subretinal fluid correlates with the disease activity. So the greater the height, the greater the disease activity. F is showing 5 days after the systemic steroid showing subretinal fluid with hyperreflective material. So this is a hyperreflective material. ICGA during acute phase of the disease show irregularly distributed hypofluorescent spots. So in the ICGA, it will be the hypofluorescent spot, which may remain hypofluorescent during late phase when the diffuse hyperfluorescence over the posterior pole is also shown. ICGA is useful for monitoring. So it is useful for monitoring the disease. So what is the treatment? Treatment is basically, it is a immunological disease. So we start the systemic steroids. High dose 1 to 2 milligram per kg per day, oral prednisolone. tapered over 3 to 6 months. This may be preceded by intravenous methylprednisolone pulse therapy 500 to 1000 milligram per day. Topical steroids and cycloplegics are used for anterior uveitis. Steroid resistant patient may require immunosuppressives. Biological blockers such as infliximab should be used early in the course of the disease if there is no response to the steroid. So basically, systemic steroids are the mainstay of the treatment. Next is the sympathetic ophthalmitis. So basically, it is very much similar to that of the VKH, but the thing is that it is associated with trauma. Sympathetic ophthalmitis is a bilateral granulomatous panuveitis occurring after the penetrating trauma when the uveal prolapse may have a feature of the trauma. Sympathetic ophthalmitis is bilateral granulomatous panuveitis occurring after penetrating trauma when uveal prolapse may have been the feature of the trauma. So basically, it usually when the one eye is having a penetrating trauma, sometimes there are other eye can also be affected, and there is the bilateral granulomatous uveitis just like a VKH. Less frequently, the condition occur following intraocular surgery, usually multiple vitreoretinal procedures. The condition have been associated with specific HLA halotypes, which suggest that in some patients there is a genetic predisposition. Presentation in trauma-induced cases is about between 2 weeks and 3 months after initial injury in 65%. So basically, it occurs 65% of the time between the time 2 weeks to 3 months when the injury occurred. The disease is probably 0.2 to 0.5% of the injury and 0.01% following intraocular surgery. Histopathology shows a diffuse lymphocytic infiltration of the choroid. So there is going to be the inflammation of the choroid, and lymphocytes are infiltrating the choroid. Scattered aggregates of epithelioid cells are seen, many of which contain fine granules of melanin. Talon-Fuchs nodule, which also occur in Vogt-Koyanagi-Harada syndrome, are granulomas located between the Bruch's membrane and RPE. So Talon-Fuchs nodule are basically the granuloma which is present between the RPE and the Bruch's membrane. So what are the features? Symptoms: there is history of a causative trauma. The exciting eye is frequently red and irritable. The sympathizing eye develops irritation, blurred vision, photophobia, and loss of accommodation. So one eye is basically exciting eye, which is basically the one which has been traumatized, which is red and irritable, and other eye is sympathizing eye, which is basically not traumatic, and it will develop irritation, blurred vision, photophobia, and loss of accommodation. So anterior uveitis develops in both eyes, which may be mild and severe and usually granulomatous. So it is also like VKH is a bilateral granulomatous uveitis. The severity of the inflammation may be markedly asymmetrical. Fundus: multifocal choroidal infiltrates develop in the mid-periphery, which serve RPE infiltrate corresponding to the Talon-Fuchs nodule. So there is going to be the multifocal choroidal infiltration and Talon-Fuchs nodule formation. Exudative retinal detachment, vasculitis, and optic disc swelling may all manifest as inflammation settles. Residual chorioretinal scarring may confer a sunset glow appearance similar to VKH. So it is all like similar to VKH, but just